Super. So, welcome everyone to the last session, the last day of this. What a wonderful academic feast that we all had for last 3 days. We're all glued here on our laptops and phone screens. So, but the last, but absolutely not the least, this is, I think, one of the very exciting topics that we are about to hear with the super distinguished our chairpersons and the speakers. So the last session is about sensitive conversations. Really a special topic because, other than even the palliative care physicians themselves are a little scared to initiate, discussions about palliative care in children and something like intimacy and sexuality. These are, even the palliative care physicians find it difficult to address these issues. And that is what you are going to listen from our experts in the field. So this will be done in two parts. Part one is about sensitive conversations with children. And we will go ahead with our part one first. I would like to invite our distinguished chairpersons. We are really honored to have with us Dr. Manish Sharma. Can we have his CV, please, here? So Dr. Manish Sharma is the Registrar, Rajasthan Medical Council, and he is the pediatric intensivist, and he is in charge of accident and emergency in Jekyllon Hospital, in charge of PICU, Jekyllon Hospital, state nodal officer for organ and tissue transplant, and he is also a receiver of a State Merit Award for extraordinary work in the field of organ transplant and critical care. So we welcome you, Dr. Manish Sharma, as a chairperson of this special session. I would also like to honor here Dr. Reena. Dr. Reena is, we closely work with her. She is the medical director, Can Support. She's been working for last 13 years in palliative care. Her areas of interest are subcutaneous drug and fluid administration in palliative home care, and managing malignant bowel obstruction and delirium in palliative home care. She also has in her kitty many publications in national and international journal. So over to you with the session on sensitive conversations with children. To Dr. Manish.
Thank you so much, Madam. I mean, as I was talking off the line, not on the air for the conference. This is a wonderful conference organized by Indian Association of Palliative Care. Hats off to Anjum and the whole team. Anjum is also wife of my batchmate, Dr. Shabbar, who is an adult intensivist. So it's a wonderful conference. And yes, I have seen that right in Jaipur, a lot of my friends are actually today on Sunday also, they are joining the conference, and there is a good vibe in the air about this conference going on. And as a pediatrician and as a in charge of pediatric critical care in my hospital and medical college, I would definitely love to have a pediatric palliative care wing in my hospital. Thank you so much for inviting me to chair this session. I would like to invite Dr. Lulu Matthews. She is also a pediatrician, MD Pediatrics and PG Diploma in Palliative Care Medicine from Cardiff University, Chairperson and Board of Examiner for Indian Association of Palliative Care, and Program Director for the Academics for the Institute of Palliative Care, Kozhikode. So I would request Dr. Lulu to deliver her session and let the people enjoy with the presentation.
So a good day to all. So here we are, both of us here, Lulu Matthews as well as Spandana. So we are both basically pediatricians who are now working in palliative care. I work in a setup where I mostly see adults now and also children. But Spandana exclusively caters to the needs of children. And today's the topic is on sensitive conversation, talking to children and their families. Next. But I just want to make it very clear. So we would rather like it to be a communicating rather than conversation. Why? Basically because you see, when you converse, it is just an exchange of words. Whereas when you communicate, You want to transform your thoughts and words into meaningful action. And hence, I would say, conversation typically involves what you wish to share, whereas communication is all about what you wish to accomplish. So here, we will be talking about how to communicate with children and their families. Okay. See, Spandana, I'm just make it very clear. And who are the children whom you often talk to? I'm sure you will be talking to them in various situations. Which are the various situations?
A lot of times when we say sensitive conversations with children, we are thinking of children who have life-limiting and life-threatening conditions. But also we have to remember that even those of us who practice adult palliative care have to remember there are children whose parents need palliative care, whose siblings also need palliative care. Sometimes children bear witness closely and sometimes partially to the suffering of an extended family member, like a grandparent or an uncle, or even friends. So we have to keep in our mind that children don't just mean those with life-limiting and life-threatening conditions, but also those who witness all the suffering of their family members and friends.
You see, but I would like to make it very clear. You see, in palliative care, the communication is not just between the child and the doctor or the doctor and the parents. Next, it is almost like a huge junction, you see, where there are underways, overways, crossovers, railway bridges, altogether cluttered. You see, this communication also between the kid and the siblings, the parents and the siblings and the doctor and the parents, the doctor and the child. So it is not just a two-way dialogue. It is multi-directional. So we have to give attention to all these facets. Right. So now, Spandana, you said there are various situations. Actually, why should we talk to children? Aren't we talking to their parents or carers? Is it not enough?
We do have to remember that communication helps us build a partnership. It's not just important to have it with parents, but it's also important to have it with children who are receiving treatments. And it's also important that even children receive information about their care plans, their treatment options, what is happening to them, and what is likely to happen in the future. And I think a major thing is even to understand their ideas, hopes, and expectations of what their condition is doing to their body and to their life. And communication, especially when we talk about children, along with verbal and non-verbal, a major part is play. And play is something that we have to keep handy and ready whenever we deal with communication with children.
Next, you see, often we see children playing for fun, but the next picture, the side-by-side picture shows children playing. That photo is taken from my leukemia ward. Here the children are playing to forget pain. Same is the condition with sleep. Next. In the first picture, you see a child waiting in front of a doctor's consultation room. So she is sleeping to forget her pain. Whereas in the next picture, side by side, you see a fellow calmly, peacefully sleeping. So even sleep has, you see, two meanings. Okay. And now, Spandana, I'm sure there are so many myths regarding communication in children. And what are these myths? Something about the myths.
A lot of times, we as practitioners forget that children have a need to know. We say that young children do not need to know. And we also say children can adjust quickly. They're lucky because they're so young that this all happened and they don't understand anything and it's good for them. And also we say things like adults better avoid topics that make children cry. And also whenever we see an active child who is playing, we think that they do not have any kinds of worries. And then children do not worry as much as adults is the other thing we keep hearing. And the whole thing that it's better not to tell children anything. And the last and the biggest is that children should not be told about death and its possibility.
Next. Yeah, you have come to the crux of the problem. See, do you really think you should disclose about death to these children?
It's not just what I think, it's also that there is research pointing towards this. It says that children, when they're dying, they can sense the stress that their caregivers, both their parents and doctors, are going through. And because all of them are together in it and they are away from all this conversation, they feel isolated and lonely in the face of the illness and also the impending death.
Yeah, I think I just talk about one of our patients, Afsal, a 7-year-old with leukemia. He used to say, I cannot become a doctor, but my brother will become a doctor. So you see, he was foreseeing his death. And moreover, he was telling, my brother will become a pediatrician who looks after kids without fees. So we were quite surprised. We asked the mother, why is he talking like this? So the mother told, whenever I consulted a particular pediatrician, even if it was on a daily basis, he used to ask for his fees. So, I mean, Afsal has not mentioned anything about this to his mother, but when he was with us, he made this statement and also made it very clear that he was sensing his own death. Next. See, we should disclose, but do you think there are any advantages in disclosing this to children?
Certainly. The advantages are more than we can imagine, because the first thing disclosure brings is the honesty through open communication. So this will help the child to develop better coping skills with the situation. A lot of times, whenever there is no open communication, the family dynamics get very stretched and not easy for them to handle. So this honesty helps them strengthen their family dynamics, and it's also important in relation building. And whenever there is disclosure, this gives time and space for the child and family to do some memory making. And the last one, but definitely not the least, it gives some control to the child to create their legacy when they have information.
Yeah. So you see, legacy is not only a matter of grandparents and parents. Even children think about legacy. Again, Ayana, 3.5-year-old, neuroblastoma. Her words, don't cry, Amma, stroking mother's cheeks. I will not die. I will not go away. I will come back as Kunyava. Kunyava in Malayalam means a small child. Okay, I will come back as your Kunyava, giving hope. So that was Ayana's legacy. And about 2 years later, her mother phoned us and told she has had a new baby, a baby boy, whom they named Ayan. So it was truly Ayana's legacy, She was very fond of pink color, and she bid goodbye to us in pink nail polish, pink dress, holding a pink doll also. So that is about legacy in children. Next.
Thank you for sharing this, ma'am, because it makes me wonder, if a 3.5-year-old has so much awareness, what about all rest of the children that we see? We do have to be aware about their thoughts, and we should create the space for them. Thank you.
Definitely. See, that brings to the next point. See, all kids are not alike. So I am sure some amount of individualization is also required when you talk to children.
I agree, ma'am. A lot of times we do have to remember, just like whenever we deal with the medical part of it, we individualize the treatment for the child or even the adult. We have to remember, whenever we are dealing with the child, especially in communication part, it has to be individualized, and the child has to guide the conversation. And always, even before you start disclosing, have an open communication with the parents. Do remember that parents, at the end of the day, are the experts on their children.
Next. But you see, sometimes parents are not the best experts. This again, is a 16-year-old boy, Alex. He was having a huge fungating mass on his neck, and one day it started oozing. So we knew he was about to die. So, but his parents would not agree. No. He has had bleeds like this before. Nothing. But then Alex told us, I want to talk to a priest. He was a Christian boy, a Catholic. So we called a priest. They both had a session, and he said, I want to confess. He had a confession, and the next day he passed away. So here you see, the parents were not allowing us to even talk that his death was imminent, but Alex knew about it. So parents need not always be the experts, especially when we deal with adolescent kids. Similarly, Spandana, do you remember any child who is fresh in your memory from the manner in which, something which that child talked to you?
This brings to my mind a 13-year-old girl with recurrence of rhabdomyosarcoma, treated at some other hospital, sent to our department of palliative care at MNJ. The first day when I was talking to her, her parents were sitting in the front and she was sitting in the back. So I just wanted to get a feel of what the parents knew, and I asked, does the girl know what's happening? And she immediately, and parents said, no, she doesn't. We want to send her out of the room. And so angrily, she immediately budged into the conversation. And she's like, I know everything. I know I'm going to die. Please stop it. And parents were horrified because they didn't know that the girl knew. And I didn't know the family dynamics. I was very quiet. And my question was, how do you know this? I mean, why are you saying this? And then she said, because she kept asking her parents and they never responded to her. When relatives came into the house and they sent her into the bedroom to have the conversation with the relatives, she switched on the audio recorder of her mother, left it there, went into the room, and after the relatives left, she went back, switched off the audio recorder, played the whole thing, and she heard it. So it's amazing how children try to find out what is happening to them. It's the curiosity that gets to them because no one is sharing anything with them. So
yeah, they will resort to any means to get to know what they want to know.
Yeah, next. And now that we have Google, children always Google what is happening even before the parents understand the reports. And this is one very interesting article in NAJM in 2004. And it's about a survey that they have done on parents who lost a child to cancer. And after the death, they went back and did this survey. So in that survey, 147 parents chose to speak to the child about death. And they said 100% of them were happy that they had that conversation. Whereas 258 parents, I think these are similar numbers to what we see here. 258 parents chose not to speak about death. And what is interesting is 100% of them were not happy. In fact, close to 25% of them regretted not talking about it. They wished they spoke to their child about it.
So, any ideas, Spandana, what is it that a child wants to know when a child becomes sick? What is it?
Yeah, this is a very interesting question because pandemic has made so much information available to children and parents have started speaking about taking care of themselves. And there are a lot more questions now. And there is a mnemonic they use, the 5 C's of what children want to know. The first thing is, did I cause it? It could be any kind of illness. Can I catch it? Can I cure it? And who is going to take care of me during this illness? And the last, but again, one of the most important part of it is, how will we stay connected during this time?
See, this connection is very important as Spandana, as you say, because you see, it can occur in various levels, I remember Robert, he was a boy from Mumbai. He had a relapse, returned to Kerala, very bad prognosis. But you know what? He kept on repeating, I have not had enough time with my mummy. Will you forget me, mummy? And he did not want to be separated from his mother. So, he used to again and again say, will you also come with me into the funeral pit? So that is so, this mother, used to cry such a lot. Whenever Robert used to make this statement, he wanted to, to maintain that connection with his mother. Because he said, I have not had enough time with my mommy. So that is it. Connection is very, very important. Then again, now I think, Spandana, you should give some tips how to start their communication with children. Okay, how do you do that?
Just like in adults, I think the first part is checking the perception, even asking what the child understands about what is happening to them. And we cannot do this like an adult. It's not just sitting for a session. This has to be done only after building a rapport. And again, we have said this previously also, allow the child to guide the conversation. And the golden rule anywhere in excellent communication is listening, and always listen to what the child is telling you and let the questions come from that conversation.
Guiding the conversation, very important. And now again, adults are very hesitant, how to start a dialogue. See, you should start with something like, suppose, or do you like movies? Do you like singing? Who is your favorite singer? Who is your actor? Like this, you start with a very common thing. Then how are things going for you next? Then, as Spandana said, finding out how much the child knows. Suppose it is leukemia. So, have you ever heard of leukemia? Do you know what it means by the word leukemia? Can you tell me what you know about it? Suppose the child says, I don't know anything. That means he does not want to talk about it. So bye-bye, tata, come back the next day. And again, you start the conversation. Then some children like to know all there is to know about their illness, whereas some children prefer not to know. Which one are you? Suppose he says, I'm like the one, I don't want to know. So again, it is tata, goodbye. Suppose he says, I want to know, then you can go to the next step. Okay, a warning. Something like, see, I need to talk to you about something. You might find it a little bit difficult or sad. Can I talk to you about it now? Or when can I talk to you about it? Do you want me to call your parents or your siblings? So step by step, slowly, gradually probing. You can start the communication and then gradually even reach the stage where you tell him give him the unhappy news. Okay. So again, about disclosure to a child, how do you go about it, Spandana?
There are many ways. I think few important things that we do have to remember is the words that we use should be developmentally appropriate. Sometimes children are in the hospital for so long that they understand words beyond their age limit. Whereas there are some children, it's their first time in the hospital and they have never seen anything, and even something like get an IV line or things like that wouldn't make sense to them. And also drawing pictures, if time permits, doing science experiments is one way to help children understand what is happening to their bodies and what is being done for them. And in pediatrics, again, especially when dealing with children, we keep saying one explanation may not be enough. Do not assume that the child understands after one session. A lot of times you tell them something really bad, then you see the child playing within an hour, and then they come back to you if you give them the opportunity and you have to do it again. And always children need more repetition to process whatever we are telling them. And the most important thing is that being honest with the child is sentient to the whole conversation that we are going to have. Never tell a child something that you do not believe. Never tell a child something you don't think is true. And always be okay with saying, I don't know. I think a lot of Asian cultures teach us always to answer something first and then think about the repercussions. But especially when dealing with children, it's okay to say, I don't know. I don't know the answer to this. Let me find out is okay.
The developmentally appropriate is very important, Spandana. For example, you see, suppose you ask a child, do you have pain? A child may not know what pain is. He may be talking ouch or couch or something like that. Similarly, in Hindi, I don't think a child will understand if you say dard. Again, it may be a simple thing which is often talked at home. So developmentally appropriate wording is very, very, very important. Okay. See, next. Spandana was talking about pictures, you see the pictures here. You give a piece of paper and pen and ask him to draw a picture. You see the top picture, a small tiny child against a closed door. So you see, what does that convey? So the child feels as if she is alone against a closed door with no communication whatsoever with others, no relationship with others. And again, below the picture on the left side, you see 3 adults talking, and again the child is lying down. So what is going on in the child's mind? See, adults are talking, as Spandana was relating that history about the mother and the family talking and the child leaving that audio recording on. So here also, the child is expressing the thing that people are talking about me, but they are not letting me into their conversation. So even pictures can talk what the child is going on in the mind of this children. See, again, the $1,000,000 question. Children sometimes they ask, am I going to get better, doctor? How do you manage such children, Spandana?
Especially when we are successful in creating the therapeutic relationship, they are going to ask this question to us. And a lot of times, again, remember, child has to guide the session and the conversation. So it's easier to redirect the question so that we can probe into what the child actually wants to know. So some easy responses that we use a lot is, why are you asking that question? Why do you ask? What do you think? I can tell that you have been thinking about it. What do you think? What are you worried about? So these are some questions that will help you understand what the child is thinking when they're asking the question, am I going to get better?
So you see, again, talking, sometimes children, will I be cured of this? Again, I'm coming to our child, Ramya. He was diagnosed with osteosarcoma. So one day in the morning, the duty doctor called me. Madam, she's asking, will I be cured of this? I think you need to come there. So I went there and asked, okay, Ramya, what is it? I want to know, will I be cured of this? I asked, what? What? Cured of what? And she told me, I'm having fever. I just want to know whether I will be cured of this fever. So you see, never guess anything. So she was just talking about the fever she was having. And again, as adults, we always think of all complicated things. So that is it. Okay. And never ever try to guess what a child is going to tell you. Never ever guess. Again, I'll tell you about one of our patients. Next slide. So she was actually about to undergo an amputation. So about a week prior to the surgery, so we asked her, so as a counseling session, are you worried? She said, yes, I am worried. And that we started worrying, hearing that. So we asked, why are you worrying? Just as Spandana was telling, why? What do you think? What is in your mind? Next slide. Then you know what she said? I am worried after the amputation where I will wear my anklets. So that was her worry. That's what I am telling you. Don't try to guess what is in a child's mind. As Spandana said, let them guide the conversation. Let them guide the talk. Then we will get to know what actually the child is thinking. Okay. So I think, Spandana, it's all about, practice. Is it not? You have to keep practicing to communicate properly with children.
Yeah, ma'am. I was just thinking about how you and I have seen so many children, and that's why we have so many stories to share. And there were times when it was truly difficult and we have to learn the lesson the hard way. And a lot of times it's easier to have some ready-made sentences borrowed from somewhere, use it in our own language at our practice, and find the best ones that suit us and go with them. So some of the statements that we use are, what are you worried about? Right? And sometimes when we have to answer that it's not going to get cured, sometimes no matter how hard everyone tries, the body can be fixed. And the difficult questions, no one knows for sure, but what do you think? To understand what the child thinks, and that's a good opening. And there is another question, as Lulu ma'am has said, a bye-bye or go forward question. Sounds like you want to talk about what might happen if you can't get better. Do you? So it's in a way, it's also in a way, I think, planting the idea that they're not going to get better. And you're giving them an opening to have that conversation. Even if they say, no, I don't want to talk about it, there is still this idea that, oh, maybe there is a chance I'm not going to get better. And if we reapproach with this question later, I think the child would have thought about it and opens to us better. And it's also important to remember we are almost at the end of the session, and there are a few points we would like to highlight for you to remember, one of which is being honest. The other is working towards developing a therapeutic relationship. Always remember, unlike adults, we do have to think about child appropriate language based on the age of the child. And whenever they use fancy words like karyotyping, metastasis, pleural effusion, we want you to think about asking them question, what does that word mean to you? What does cancer mean to you? What does metastasis mean to you? Because a lot of times they parrot the words they hear their parents and doctors using. During the rounds, a lot of times we are not very sensitive, right? So we say it's a osteogenic sarcoma, metastasized to lung. And the child is quite smart and he picks up that word and he'll tell you what is happening to you, metastasis to lung. And it might not mean anything to them. And always be prepared for emotions. And sometimes after your conversation, there can be no visible reaction and you're waiting for the emotion and it doesn't come. It is going to come later, but not in front of you. So always be prepared for that also. And the whole conversation, I think, of bringing this up in a conference is because a lot of time children choose to ask healthcare providers these questions when the parents are not around. When there are no other adults stopping them, they pick a healthcare provider that they trust and they ask this question. Remember not to shut down the conversation because you did something very right that they trusted you to ask that question. And as we said, if you're not sure or if the question is very tough, always redirect back the question to them. Right? So, and also it's okay to say, I don't know, I'll come back with the answer to you. And always thank them for sharing with you because it takes a lot for a child to trust and ask a question. Just go back to your own childhood. How many adults were there that we trusted to ask questions uninhibited? So if they chose you for that, it is in a way an honor that they chose us to ask that question. So always thank them for sharing that question.
Okay, now can you just list the strategies used? 1, 2, 3.
Always remember the power of hello. It doesn't even have to be that they are my patient, but whenever I see a child in the ward making an eye contact, sometimes I even say hello myself. I just say hello and I move on to my palliative care patient, right? And every time you're doing even a simple examination, a simple procedure, always tell what is happening. I'm going to touch you with spirit and it is going to feel a bit cold. Something as simple as that, they know that whatever I do, I'm going to tell them. And always ask more questions to understand what is happening. So if a child is not taking medications, like you said, instead of noting down as incompliant, we can ask a question, tell me about why you are having a hard time taking your medicine. It could be something as simple as every time I take the tablet, I feel like vomiting. Or I did not have my breakfast in the morning and I thought this medicine has to be taken only after food. It can be something as simple as that, and you saying this medicine doesn't have to be taken after food will ensure compliance. And always offer choices when appropriate. When I say this, what I mean is, even simple things like whenever I do a procedure, I ask them, do you want to put your head on this side of the bed or that side of the bed? Like the head end or the leg end, if it's comfortable for me to do the procedure. And especially subcutaneous lines, we offer them 2 or 3 sites for choice because all said and done, it is still painful and the child has to sleep it on the arm or the leg or the abdomen. So we say, is this a site that you're okay with? And I think it offers them some kind of control on what is happening. And always remember, sitting next to someone makes a lot of difference. Think of your hard time in life and just imagine if someone sat beside us when we were going through, how it would have felt or how it felt if you had someone to sit next to you. So remember the power of sitting next to someone. Remember the power of touch. Touch both to reassure and also to establish boundaries. And whenever there are adults and also a child in the corner of the room, try and address all the people in the room. Make the child feel seen, because a lot of times as children, we don't feel seen. And we don't want to do that to the next generation. And always see the patient beyond their healthcare condition. They're not just a sum of their reports or their symptoms, but there is so much beyond what they present to you in the hospital. So try and see that part of them, and it makes a lot of difference for them. And also, this picture is something we use again and again. Here, a doctor, seemingly quite senior, took the time to bend, sit, and talk to the child. He's trying to come to their eye level. And I think that makes a lot of difference for that child, that an adult considers them worthy enough to make that effort. So be that person who makes that effort and makes the child seen and heard.
So while communicating with children, I just want to repeat, don't be judgmental, don't be patronizing, don't interrupt, don't use commanding voice or tone, don't ever compare children with adults, don't show displeasure with them, and don't make promises that you can't keep. If you tell them that I will give you a Cadbury, remember to buy a Cadbury and take it to the hospital next day. If you don't have it, they will lose their faith in you completely. And again, yeah, next. So now that you have the strategies have been mentioned, I think it is at the end of time, and we will just summarize what we have been mentioning so far. Okay. So just do what you can and when you can. See, there is more than one way to support children. And as we practice more and more, we develop our own techniques. Okay. And choose the things that you feel most comfortable with. Don't try to ape what is happening in the West. It may not be natural, it may not come natural to you. So develop your own techniques and accept that some things just can't be made better in a short space of time. We have our own limitations. Talk to children using words they understand. Okay. And our culture is very important. Our language, our dialect, that's all very, very important when we talk with children. And give information a bit at a time, not all together. And encourage children to ask questions, okay, and answer them as honestly and as simply as you can. And as Pandana has pointed out, give them choices so that they think they have a control over what's happening. Keep the children and the entire family involved. Don't ever forget the siblings. Don't ever forget the siblings. And again, the carer express, so look after yourself because you might get yourself burnt out. Okay. And now just a word. Never ever argue with children and never ever argue with the parents of the children. However tiny the child is, the child will understand, oh, this doctor is fighting with my mother or with my father. So that this doctor is a bad doctor. So that is it. Never ever argue with children or their parents. And one last thing, children often know lots more than what we think. I remember a 9-year-old girl with brain tumor clinging to her mother. She used to say, I'm frightened to die. Be with me. Don't leave me. And you see, they had a neighbor. She used to call him uncle. So she requested that uncle to marry her mother because she was a single mother. And she requested the uncle and told him, my mother will be alone once I die. So I want you to marry my mother. Just imagine a 9-year-old talking like this. So you see, they know much more than what we think they know. And again, this uncle, when she was admitted in IPM, this uncle brought her in Bermuda. That is the picture I've shown here. Then she loved it so much. And she used to say, I want to wear this when I go. So in fact, her mother made her wear this Bermuda when she finally left us. Next. So I think we have come to the end of it. And thank you all very much. Thank you from both myself and Spandana.
Thank you.
The presentation, such an interactive way of presenting it, I think it moved all of us. The chat box is full of all the praises for both of you, ma'am. And I think I am left without words. Dr. Manish, you want to say something? You unmute?
No, madam. I mean, That was a amazing presentation, and what we have been doing and what is in practice is something very, very different. And what Spandana told me is something. I mean, the presentation was absolutely fabulous, and it's an eye opener for the intensivist like me, that what should be the approach towards such patient, because I have had just 2 days before two such patient I lost they were there in their terminal stages. But as the discussions were going on, we did nothing like that. So I think the intensive care people should at least be tuned with such kind of care.
Absolutely. So it's 2:40 and it's time to move towards the second part of the sensitive conversations, which is intimacy and sexuality in palliative care. So it'll be a kind of a panel discussion and everybody will have parts to tell about. I would like to invite Dr. Reena, the Medical Director, Cancer Support, to introduce our panelists and the speakers. Over to you, Dr. Reena, ma'am.
Good afternoon, everyone. I hope I'm audible. Thank you, Dr. Lulu and Dr. Spandana, for that wonderful session. Now we go on to the next session, which is something which is very private and personal, very difficult to talk about, very embarrassing for the palliative care professional as well as the patient and caregivers. That is sexuality and intimacy in palliative care. I'll introduce the speakers for this panel discussion. The first speaker is Dr. Biju Raghavan. Dr. Biju is a senior consultant in pain and palliative medicine, Rajgiri Hospital, Kochi, Kerala. He's had 19 years experience in palliative care, and his chief interests are communication skills, end-of-life care, chronic pain. And his major achievements are he has established departments of pain and palliative medicine in 2 tertiary hospitals, private teaching hospitals, and established inpatient service in 1 hospice. Dr. Biju will be introducing the topic of intimacy and sexuality in palliative care. The second speaker is Dr. Rajshri Casey, and it is my honor to introduce her, as she was my mentor when I started in palliative care. Dr. Rajshri, can we have her? Dr. Rajshri is an assistant professor and faculty in palliative care. She is presently working in the Amrita Institute of Medical Sciences, Kochi, and she also is associated with the Institute of Palliative Medicine, Thrissur, Kerala. She has 22 years experience, and her top chief areas of interest are palliative care for older people, end-of-life care, mental health care for palliative care patients. She has a number of publications to her credit, and she has also contributed to books on palliative care, and also to she contributed to writing to developing and processing to palliative care needs during the coronavirus disease in 2019. Welcome, Dr. Rajshri, and she will be talking about intimacy and sexuality and what it is about. The third speaker will be Dr. Priyadarshini Kulkarni. Dr. Priyadarshini Kulkarni, I'm sure many people already know her, as she is she was previously the secretary of IAPC. Dr. Priyadarshini Kulkarni is a consultant in palliative medicine at Pune. She is the founder of Ease and Support in India and the chapter lead for the Elizabeth Kubler-Ross Foundation. She has a number of publications to her credit, and she is also the author of Touching Hearts Gently. This book is available on Amazon, and it is talks about her experience, stories about her experience in palliative care. The fourth speaker is Dr. Nidhi Patni, and Dr. Nidhi Patni is a radiation oncologist. She is Director, Department of Radiation Oncology at the Bhagwan Mahavir Cancer Hospital and Research Center. She has 25 years experience, and she is her main interests are treating breast cancer, cervical cancer, and CNS tumors. Her major achievements are establishing a well-equipped department of radiation oncology way back in 1997, which is delivering evidence-based treatment to nearly 350 patients per day. And she has also been DNB guide to 20 students till date. She will be talking about palliative barriers regarding intimacy in palliative care. The fifth and final speaker for this session will be Dr. Dr. Biji MS, and she will be talking about can we make a difference? Dr. Biji MS, is her slide up there?
Yes, it is up there.
Okay, right. Dr. Biji MS is the assistant professor in charge, Department of Cancer Palliative Medicine at Malabar Cancer Center. She has 14 years experience, and her areas of interest are pain management and research in palliative medicine. Her major achievements are being national faculty of IAPC and faculty of National Fellowship in Palliative Medicine. She also has a number of publications and awards to her credit. So first, let us continue with the session. And the first speaker, let's go on to the first speaker, who is Dr. Biju Rajwan, who will be introducing the topic of intimacy and sexuality in palliative care. So over to Dr. Biju Rajwan.
First of all, I would like to express our extreme gratitude and thanks to all the organizers of IAPCON 2022. And thank you, Dr. Megha, for that extremely kind introduction of the entire panel, 5 of us here. And with that, I think I will proceed on a topic which is of extreme importance, yet much neglected in the field of palliative care. I'll start with the screen sharing. So, intimacy and sexuality in palliative care is, as I said earlier, is something not much talked about in palliative care. And I would like to just present a case so that we can get the ball rolling. A 39-year-old lady, mother of 2 children, whose husband is self-employed, was diagnosed with carcinoma cervix. The radiation therapy finished, and after 1 week, it was time for the due follow-up. However, instead of the practice of coming to the hospital for follow-up, this time the patient and the husband reported at the treating doctor's home for consultation. After all the regular checkups and the discussions were done, the husband brought up this topic. He claimed that his wife wanted to restart physical relationships, and to which the wife actually counterclaimed that she said it's actually her husband who has been suggesting the same. In the discussion, it also became kind of clear that wife was feeling hurt, and she said words to the effect that he has been less loving and not as supportive as she would have wished him to be. She also expressed a fear of pain while coitus. The husband, on the other side, accepted that he did have an intimacy distancing, but he said it was due to fear. He was afraid that he might get the cancer from his wife because he heard from many places that cancer could be contagious. He was also afraid that he might cause her pain, and he was sad, uh, and he was afraid as well that his wife may misunderstand him if he tried to be loving. Uh, and both of them said that they wished there was somebody who would have talked to them about these issues, somebody with whom they could share their concerns. And that was something they both uniformly felt. Now, this is something that is kind of new to me. I wonder what exactly is going on here. And I would, at this stage, invite Dr. Rajeshri to kind of throw some light on what exactly is going on here. What are we dealing with here? Dr. Rajeshri, can you take that up?
Thank you, Biju, for the wonderful introduction of the topic and the excellent case scenario. Today, we are going to discuss something which is quite close to our day-to-day life, but which is quite often overlooked, that it exists. That is intimacy and sexuality. Intimacy, we know, it's an emotional space in healthy human life where sharing takes place between two individuals. Whereas sexuality is part of intimacy and it can enhance or negatively affect the relationship. When the partners encounter sexual problems, it can have a long-lasting effect, both biologically and psychologically. Human sexuality, by definition, it is the way people experience and express themselves. It is a very broad term which is concerned with feelings and behaviors. It has different components like biological, physical, emotional, erotic, social, spiritual. Biological and physical components are mainly concerned with the reproductive function, the anatomy, the physiology, the hormones, and the entire reproductive cycle and the physical activities concerned with the sex, whereas emotional, erotic, social, and spiritual aspects depict even more complex aspects of human life. We have to understand that sexuality also affects and is affected by cultural, political, legal, philosophical, moral, ethical, and religious aspects of life. So we can understand that how complex and how finely and deeply it has invaded in one's everyday life. So before going to the topic, we need to understand certain terms. Sex and gender. Sex is a trait that refers to the biological sex assigned to the individual at the time of birth. And it basically depicts the reproductive function. Whereas gender is a social construct that refers to attitude, feelings, the behaviors in a given culture. And also it is associated with the person's biological sex. So when we talk about gender, there are three more terminologies like gender identity, gender expression, and gender orientation. Gender identity is a component of gender that describes a person's psychological sense of his or her gender. So that is, as the picture denotes, it is concerned with the brain's identification of own sex. It need not be, if you happen to be a male or female, it is not necessary that your brain has to identify yourself as a male or female. So brain's identity is also important with respect to your own biological sex. Whereas gender expression is the way one presents his gender through his action, clothing, demeanor, etc. So that is the external or outward behavior. Whereas gender orientation is basically with your heart, where you find yourself being attracted to or even not attracted to other people in a sexual or romantic way. So what is sexual health? It depicts, it encompasses gender identity, expression, and orientation, which we had already described. It is also concerned with body image and self-esteem. Here we have to understand that a person who had undergone reconstructive surgery for head and neck cancer, a person who had undergone mastectomy for carcinoma breast, a person who had received radiotherapy for carcinoma cervix, as depicted in Biju's case scenario, or a person who had undergone colostomy for carcinoma rectosigmoid. All of these people can have sexual issues, but on different grounds. That we have to understand. The organ need not be exactly genital to produce a sexual concern. So sexual health also encompasses sexual and reproductive function, and it also deals with sexual dysfunction as well, where each individual, whether it is a female or male, faces with dysfunction in their daily sexual life. And also it deals with sexually transmitted disease, and it has got its connection with intimacy and relationship. It definitely anchors on the legal aspects as well, where it covers the consent and boundaries, sexual abuse and violence, which is very, very predominant in our present day society. So what is a healthy sexual behavior? So our relationship with sex often acts as a barometer of our own health and happiness, about which we are quite unaware of. There is nothing like normal and abnormal, and it is purely fluid and subjective, as we discuss pain, where it is purely subjective. Here, sexual behavior also is very fluid and it is subjective, and in the same individual, it can have a dynamic aspect. Culture can have a big impact on one person's understanding and what constitutes a healthy sexual behavior. So what can be normal in a particular culture can be quite abnormal in a different culture. So this has to have a bearing in our mind when we address issues related with homosexuality. As far as a healthy human sexual behavior is concerned, the primary concerns are there should not be an unwilling victim engaged in a sexual activity. It should happen with mutual consent. And there should not be any guilt or shame arising out of a particular sexual activity. So when these three parameters are met, so sexual behavior can be considered healthy. So sexual behavior in a male and a female, it differs. And it has evolved over a period of time, and it has shaped our behavior, and it has anchored in our biological parameters as well. The catch is that none of us are aware of this difference, and we often rationalize or justify our behavior as to what is right. And when we compare a male sex and a female sex, I mean, you can see that aggression and sexual desire is more in male. That is something inherent, as we have discussed, which has evolved over a period of time. Whereas sexual can be comparatively less, and aggression also can be less in a female individual. In a female individual can expect a committed relationship out of a sexual activity or a sexual life, whereas that kind of expectation is much less in a male. And over a period of time, in female, the sexual behavior, we can see that it is more malleable, and it keeps on changing with time, whereas that malleability and change is not seen that common in male sex. When we talk about the sexual behavior, it does not mean sexual intercourse alone. It involves being together, caring, caressing, cuddling, and many more connectedness. So, like when the people don't feel connected or safe or loved or cared about, then sex either goes away or becomes mechanical. So it is fundamental that we have to have love, basically love in our mutual relationship, that reinforces a healthy sexual behavior. So let us reinvent the concept of sexuality. Thank you for inviting me to speak on this particular subject. Thank you.
Thank you, Dr. Rajshri, for that wonderful presentation. You have opened up a new window into an area of which, frankly, I wasn't much aware of. A lot of things that you have presented today is new information for me. I'm sure it must be new for at least some of us over here. And it really is actually eye-opening about this concept of sex, intimacy, gender, everything. I was just wondering, we are all palliative care professionals. Where does this important issue of our lives, of our patients and families' life, where does that fit in palliative care? And for this, I would like to invite Dr. Priyadarshini to throw some light on this aspect. Where does this fit in palliative care? Dr. Priyadarshini?
Okay, thank you. Thank you, Dr. Biju, for inviting me to talk on this topic. And thank you, Dr. Rajeshri, for setting the tone for this question to be answered in a better way. Next. So if you look at these pictures, intimacy is just not physical. It is a feeling of closeness that isn't about proximity, but about belongingness. It is a beautiful emotional space in which two become one. Next. If you look at this picture, it talks about many important concepts in palliative care. But what palliative care is that care which is focused on providing relief from the symptoms and also reducing the stress of illness. We focus on treating the person with the disease, that is, person with a life-limiting condition, and not just treating the disease. And our goal is to improve quality of life of both patient as well as family member. Next. Next. If you look at this picture, you can easily see that there is this gap between reality and expectation, which makes quality of life of any individual better or worse. It's a very subjective perception. The closer our expectations are to the reality, our quality of life is better. What can we expect when our patients are advanced disease? They may expect to be pain-free. They may expect to live on forever. They may expect seeing future together, or they may expect to be loved and cared for by their loved ones. And that's the quality of life we are talking about. Next. So, in addition to symptom management, quality of life depends on quality of your relationships. Next. 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 So, when we are talking about palliative care and 4 quadrants of care, patients suffering, and we are talking always about physical, social, psychological, and spiritual components of care. Next. This picture on right hand side, there is a concept called elephant in the room. And we know what elephant in the room we are talking here on. Somewhere between social, psychological, and spiritual components of care, even though all of us know that sexuality and intimacy remain the important part of many people's lives, regardless of their health, and it needs to be incorporated into their care, it is often forgotten or not given that importance it deserves. Next. Next. So when we concentrate on family members, those who are going through this difficult journey of palliative care with their loved ones, they are too overwhelmed. They are also suffering. They know that their loved ones are not going to make it. It is very difficult for them to accept the death, even if they know that it is going to happen to each and every one of us. And in that overwhelmed situation, they find it very, very difficult to address potential need for sexual expression. As it is said by Elizabeth Kubler-Ross, it is not the end of physical body that should worry us. Rather, our concern must be to live while we are alive, to release our inner selves from the spiritual death that comes with living behind a facade designed to conform to external definitions of who and what we are. Actually, we need to learn to make most of what that limited time is. Next. If you look at this pot, you can see this beautiful pot with golden lines in between. It is actually a broken pottery which is repaired with gold. This is devised by Fukumaro and it is called the art of kintsugi. It is later on developed into the healing art of kintsugi. Next. If you look at couples who are at the end of their life, their time as a couple is very limited and therefore it is very, very spatial. During this journey of going through this disease, it is somewhere broken and it needs rebuilding of this relationship, even if one of them is not going to make it. It is going to be the healing process for the other one. And therefore, we as care providers should understand the potential need for sexual expression, especially at the end of life. Next. So as it is seen in this picture, this pot looks more beautiful, more valuable and more stronger because it has transformed through its suffering. We must understand that our comprehensive patient care assessment should include history of sexual health, practical ways of incorporating sexual history. What are the couple goals? We need to discuss that. We need to explore how sexual dysfunction can impair their relationship. We should be talking to them about anticipated sexual changes, treatment related side effects, what is tolerable and intolerable to patient, because only then we can have comprehensive patient care. Next. So, in short, as said by Dean Ornish, intimacy is healing, and we as professionals need to include this history as a part of our history taking. Thank you.
Thank you, Dr. Priyadarshini. Again, and another excellent presentation and eye-opening presentation, I would say, for beautifully giving clarity on why suffering related to intimacy and sexuality should and must be a part of as a palliative care professional in the whole area of suffering that we deal with. It's amazing that it is not often that we even talk about this. And thank you for bringing so much of clarity in this area, which is often neglected. I know for sure that it is not something that I focus on a regular basis. And that brings to my mind why it is so. What is the problem? Why, as palliative care professionals, we are neglecting this such an important aspect of our patients and their families' existence? And there must be something wrong somewhere. And I invite Dr. Nidhi to throw some light on it. Dr. Nidhi, what exactly is the problem? Why are we not dealing with this issue on a regular basis? What is the barrier? Why are we not doing this? Dr. Nidhi, over to you.
Thank you, Dr. Biju. So, despite living in the shadows of impending death, evidence suggests that the expression of sexuality and the need to connect in an intimate way continues to be an important part of people's life, even in their last weeks and days. And there are various barriers to this concept and this problem and this issue that we are discussing today. It starts right from the bottom of the pyramid, which consists of the society at large, honing down to the healthcare providers, to the family, to the spouse, and then to the patient who sits at the pinnacle of this pyramid. So, when one person is seriously ill, the dynamics within a couple are altered. Adjustment is required as they negotiate the range of challenges that progressively the illness brings. How people express themselves in close relationship is socially and culturally determined. However, it is generally accepted that human beings need to communicate. They need to receive the love that is done in a variety of ways. As they approach death, people's need for physical closeness, to touch and to be touched, may be much more significant in terms of quality of life. And the concerns of the patients are very obvious. Coming to the physical concerns, the patient is obviously concerned about self image. A patient who has recently undergone mastectomy, she feels she's not complete as a woman. Similarly, weight gain by virtue of chemotherapy or hormonal therapy, hair loss following chemotherapy or radiation to the scalp, then the patient feels that he or she is sexually unattractive for various surgeries. There could be facial disfigurement after head and neck cancer treatment. Coming to the physiological aspects where male and female have different challenges to face. In a male patient, whenever there is a surgery in the pelvis or radiation delivered to the pelvis, the patient may experience erectile dysfunction. There could be loss of libido, there could be premature ejaculation, there could be loss of fertility. Coming to a female patient, a patient who undergoes radiation to the pelvic region for carcinoma cervix or uterus or rectum may experience vaginal dryness post-radiation, which leads to painful intercourse. The patient's vaginal length may be shortened after the hysterectomy. Similarly, the patient may find inability to attain orgasm. There could be loss of libido, early menopause, post chemotherapy, or because of the hormonal treatment, and loss of fertility. Coming to the emotional and cultural issues, anxiety, guilt, sadness, depression, hopelessness, and frustration are certain issues which bother each and every patient either at one point of, or the other throughout their ailments. So intimate expression is especially vital at the end of life when relationships with loved ones are time limited. So the concerns the spouse face are, there could be some general concerns like longevity of the patient, the quality of life of the patient, the socioeconomic concerns, parenting, and of course, the treatment and the diagnosis brings in the changing roles and responsibilities within the family. And the entire plans for the future have been jeopardized and they have to replan for their future, their offspring's future. When someone is living with a life-limiting illness, their coupled relationship is also done. It becoming apart as a couple is experienced as a loss of spontaneity, as lack of reciprocity and rejection. This is influenced by a range of factors. So the relationship concerns is that the patient or the spouse may think that what will the patient think if I bring up this topic of intimacy or sexuality? The spouse is also scared that if I come in close contact with the patient, I may contract cancer from him or her. The spouse often feels that I don't feel the same about her or him anymore. Somehow the things have changed between us. My spouse is too weak for any physical relationship. And the hygiene issue, like the general hygiene, genital and oral hygiene, they also compromise at times and they may even become deterrent. So disconnecting and connecting intimacy with the partner having a limited lifespan is natural. But as far as we, the providers, are concerned, the healthcare individuals are concerned, our concern usually is to provide the optimum cancer treatment, to look after the regular follow up, to look after the quality of life issues, which definitely include intimacy and sexual health, are usually ignored. And when we come to the palliative care, this important issue becomes even more important. And the causes that we usually come across and which have been seen in the literature as well, which are definitely barriers when the healthcare providers are providing the palliative care to these patients. So the lack is either one or more of the following causes. Either we are lacking in thoughtfulness, the initiative is not there amongst the fraternity to raise this issue with the patient or the spouse. We do not have the confidence because we are lacking in knowledge and experience to deal with such delicate issues with the patients. And even if we are having all the access to all the above five, suppose we are thoughtful, we have initiative, confident, knowledge, and experience, there are times when we do not get enough privacy to discuss such issues with the patients, or we are loaded and overloaded with the patients, and lack of time leads to such problems in dealing with the patients. But sexuality is an integral part of uniqueness and personality of every human being. Failure to acknowledge this aspect of an individual in the palliative care context implies failure to acknowledge personhood. The ethos of holistic care require palliative care professionals to overcome all barriers and provide opportunities for patients and their partners to discuss and address any such concerns they might have about their coupled relationship. That is what my perception is. Thank you, Viju.
Thank you, Dr. Nidhi. That was exceptional. While you were presenting your, while you were through your presentation, I was thinking back at our case scenario, and suddenly I was, getting enlightened. What possible barriers these couple must have been facing, and thank you for bringing that. And your words resonate in my head. The failure on our part to acknowledge personhood. That was substantial. It is one line, but that is heavy. Our failure to acknowledge personhood. So that means we are not exonerated from our responsibility, or not being not doing enough from our part as palliative care professional to look into the suffering related to intimacy and sexuality, not acknowledging personhood. And you have brought in so many areas of barriers, but I am now looking for solutions. What can be done? And for this, I am turning to Dr. Biji. Dr. Biji, would you kindly enlighten us on what we can do and what we can start off with? Dr. Biji, over to you.
Thank you, Dr. Biju, for inviting me for this lecture. And
Biji, we lost you.
yeah, thank you, Dr. Biju, for inviting me. And thank you all my previous presenters or the speakers who had discussed these various aspects of sexuality in such a wonderful manner. And so now the question is, what can we do as a healthcare worker? Can we make a difference in their life? especially like the patient Dr. Biju had discussed in the case scenario. So before we go into the answer to that question, I would like to quickly run through the key results which I had got in a study which I had done on similar patients like what Dr. Biju had described. So I had done the study 2 years ago, and the key findings are so. The interest in their sexual life, that is around 67.8% of those survivors, they had low or no sexual interest. 42.5% of the survivors, they were dissatisfied with their sexual life. And more than half of them, they did not have any sexual activity since the completion of their treatment. Now, this completion of treatment, the median time period after the treatment was completed was 22 months, nearly 2 years. So the range between 12 to 120 months. Moreover, the reason for this lack of interest in these females when I inquired, it was that in 35.5% of the patients, the reason was they did not have any instruction from the treating physician regarding when to restart their sexual activity. And what they actually expected, 94.3% of the survivors, they felt that their treating physician should have discussed about all these treatment problems prior to starting the treatment. And more than 92% of these survivors, they even wanted this to be discussed with their spouses, or the spouses to also to be involved when the doctor is supposed to discuss all this to them. And yet another observation and what my inference were that patients and these spouses, they were very much share all their sexual problems with the healthcare professionals like us. So they were so thankful for the minimum time I spent with them to listen to these problems of them. And a few of them, they said they were so very relieved of their stress also by clearing all the misconceptions they had regarding their sexual activity, whether they can continue it right now or not, what yes or what no, whatever answer they wanted from me. So they were so much relieved of the stress, they said. So obviously, what is the answer to this question? It is sexual counseling. It should be either pre-treatment sexual counseling, or it could be post-treatment sexual counseling. Like our patient in the case scenario, we actually failed to give this part for them. The pre-treatment sexual counseling and the post-treatment sexual counseling. That is why now they have come to a doctor whom they feel will definitely give something about that topic. Maybe she was hinting that I can talk to you about that. That is why they would have come home to see her. Or it could also be an end-of-life sexual counseling. In whatever stage our patient fits in, we'll have to mold ourselves to do the sexual counseling in that particular stage. So how do we go about the sexual counseling? So Jacques Anand, he's a sex therapist or a sex educator. In the year 1974, he had created a model for sexual counseling called the Plicit model of sexual counseling. So this Plicit model of sexual counseling, it has got 4 levels of interventions. So it is represented by an inverted pyramid, and the 4 levels, the mnemonic Plicit stands for P stands for permission, LI for limited information, SS for specific suggestion, and the last IT stands for intensive therapy. So let us just see one by one. The first level of intervention is the permission. We have to give the patients the permission for them to raise their sexual issues to us so that they can open up to us. That permission has to be granted by the doctor or the healthcare professional who's talking to them. So this permission actually takes the major portion of that pyramid, which means that most of our patients, if you give them this particular level, this intervention is sufficient for them. They don't even have to go to the next 3 levels. If you can give them the permission to raise their problems or talk about the sexual issues to us. The second stage, if required, would be the next limited information. So giving the patients the limited information about what they want. So when we say limited information, that's a hell lot of information regarding sexual problems. But we don't have to dump everything into our patients and scare them. What are their questions? What are their problems? If we can give a patient hearing to them and give the required information to them, that itself is sufficient for them. So most probably and most often this second level requires us the various myths and the misconceptions like Dr. Nidhi was speaking. Those misconceptions and the myths, if you're able to clear them, that itself is sufficient for them. And a fewer patients, they have to go to the next level, that is specific suggestion. So we have to give them specific suggestions which are based on the full evaluation of their presenting sexual problem. Now, this could be in the form of either some relaxation therapy, or it could be some exercises which they can do. That is to modify the sexual behavior so that they could attain good sexual satisfaction. And very few number of patients, they might require the last intervention stage, that is the intensive therapy. Probably we could actually at this stage, when we are not able to deal with our patients who require more in-depth evaluation of them and in-depth counseling of them, we could always seek the help of other medical professionals, other healthcare or other mental or medical health professionals, maybe sex therapists, etc. So if you could refer them to this intensive therapist, the psychologists can do the psychological intervention, sex therapy, and or biomedical approaches. So, but we have to remember that very few patients only need to go to this level. Majority of our patients, they fall in the first level of intervention, which is all what they require. So the suggestion from our side for our healthcare workers would be proactive. We should not feel embarrassed to ask such questions to our patients. Only then they will be very comfortable to talk to us. So we have to talk to them in a very sensitive but explicit way. Brainstorm alternate intimate expressions, that is, which is fitting into the patients as well as their spouses' needs and abilities at that particular time. Maybe you could explore new ways of intimacy, like holding hands or kissing or something like that. Then educate on the sexual changes which can occur because of the treatment or because of the medications. Normalizing the possible changes at that particular time because of the disease which they have right now. And appropriate and timely referral of our patients, as I told you, for the intensive therapy. And above that, there are a few other suggestions which we could include, like Dr. Priya had mentioned about adding these questions on sexual history in our history taking. So including questions about sexual expressions. Right from the MBBS level, we have to be taught that this has to be a part of our history taking, sexual history taking. Second, offer continuing education. We are conducting so many CMEs around. So we have to develop CMEs which is going to focus on this particular topic. Like we have started in this IAPCON, thanks to the organizers for that. We have to conduct clinical researches on sexuality. So if you do more and more research on this, we will be able to help our patients a lot. So that total care or that holistic care, which we have been always talking in palliative care, which involves the physical care, emotional care, social care, and spiritual care, that would be incomplete if we are not giving the importance to sexual care or incorporating the sexual care into that total care. And I'm sure this can be the beginning for us, that is to start exploring this particular aspect of sexual problems in our patients, so that we make a change in their life or give them a good quality of life. And I'm sure you will all be ready for this change so that we can definitely make a difference in our patient's life. Thank you.
Thank you, Dr. Biji. Again, another excellent presentation over here. My mind boggles because more than 90% of our patients expect us to talk to them about it. I didn't know that. And I think the most important phrase is that we have to be proactive. The most important word is proactive. The onus is on us. And thank you for bringing out so many excellent suggestions on how we can provide relief of suffering related to intimacy and sexuality. And just to sum it up, a few take-home messages. First and foremost, issues related to intimacy and sexuality are integral to normal, healthy life. And thanks to Dr. Rajshri for clarifying on the issues related to intimacy and sexuality. The second important part is suffering related to intimacy and sexuality needs to be looked at as part of our total care in palliative care. And I thank Dr. Priyadarshini for throwing light on that. And there are a lot of barriers. Palliative care professionals need to overcome these barriers related to issues of intimacy and sexuality, because that is how we will be able to provide holistic care in its true sense. And thank you, Dr. Nidhi, for throwing light on the problems and barriers related to the issue. And last but not the least, let us start talking about intimacy and sexuality. Let's start educating ourselves and let's start practicing. The onus is on us. We have to be proactive, as Dr. Biji said in her presentation. Thank you, Dr. Biji, for that. With that, I hand over the I. With that, I thank all my co-panelists for the extremely important messages that they have enlightened all of us today. And with that, we come to the end of this session. And I hand the baton back to Dr. Megha and the chairpersons of today's session. Thank you.
Organizers. Thank you.
No earlier. Now, to go on to the question and answer sessions, in period for Dr. Lulu and Dr. Spandana, there is one question from the audience. They've asked what kind of science experiments. I think in one of your slides you'd written that you're for communicating with the children. So if you would like to answer that.
Thank you, Dr. Reena. Yes, ma'am. Am I audible, ma'am?
Yes, you are.
Yeah. So when we say science experiments are a way of teaching children, what we mean is even when a child is part of a very complex care adult or child who is on a Ryle's tube or a gastrostomy or jejunostomy tube or things like that, and they become a part of the whole family and they have to deal with it. And even showing them how the tube works, where it is going and how to handle the Ryle's tube, how to feed, and when we feed, how it goes, things like that, I think makes them more involved in the care of the patient and their own family member, their sibling or their parents. So things like that to help them understand what is happening with them. Yeah.
Right.
Yes.
Thank you so much. That's a great explanation. In fact,
Especially when they use it on their toys.
Yes, that becomes an experiment for them. Yes, you're right.
May I ask one question, madam?
Yes.
I'm so sorry, but it's a overriding between end of life and palliative care. Just a few days before, I had two leukemia patient in my ICU, terminal stages. I was pretty sure that they are not going to survive multiple infections. Now the question comes in. 3 days before they went on to venti, inotropy. Now I was in total dilemma that whether to increase the inotropy, whether to hover around with the ventilator, whether to do anything, because I was knowing that the child is not going to survive. I was not able to take any decision, and the final decision which I took is that let it continue like this and follow the course of the disease. But actually it was so pathetic that I couldn't take any call in it. The attendants, patient, family told me, sir, whatever you feel like, you can take a call. So it was absolutely on me. So what does you expert say in such situation?
Dr. Lulu, if you'd like to answer.
Yeah, I'll answer that. Dr. Manish, it's a very, very common problem, And you see, if you ask a child, whom does the child want to be with? The mother, with the father, with the siblings. You ask the mother, she wants to be with the child. And what do? We shut the child off in a sort of cage. The child is imprisoned there. And you see what the child sees is only nurses running around and the sound of instruments and sirens going. And the child will be looking around like this. He wants to see the mother. The child wants to hold the mother's hand. So I have been, wherever I'm invited, nowadays I'm talking about an end of life care room where you see you should charge it well. Very often, the parents are doing these things like shutting up the child in an ICU because others will say, oh, you are very cringy, you don't want to spend money. So have a end of life room, very colorful, very nice room, where there are no invasive procedures done. Just maybe a CPAP or IV fluid. That is all. No inotropic support, nothing like that. But where the family can remain with the child and music on or a TV on, where the child can see any movies or listen to music, and where the family can eat together, pray together, play together, especially the siblings. So at least, those who are working in a hi-fi, Wi-Fi hospital should start thinking about an end-of-life room. End-of-life room is a place where, you admit children whom have no chance of being cured, but whose end-of-life phase you want to make beautiful. And when the mother thinks about that period, she should feel happy. And not the thought should not be in her mind. What was it like when my child died? Was she looking around for me? I could have been there holding her hands. Such thoughts should not come to parents' mind. Such thoughts should not come to siblings' mind. So that is my suggestion. And nowadays, wherever I am invited, I talk about this end of life room, end of life care room. I hope I have answered your question.
I got it, madam. I got it, because we are getting another 2 big ICUs made. I will tomorrow only, I will ask the engineer to make a separate room for such kind of kids.
There should be one. And make it costly, because very often it is a cost factor which the parents think, oh, you are taking your child for palliative care, you are trying to save money. On the other hand, if you take this to an ICU, that will be fine. Fine for whom? Fine for nobody. Especially it is worst for the child and worst for the family. So make a very end of life room, very colorful, with pretty curtains, toys, music, TV, radios, and playthings, and where the parents and the siblings can come together, and a small facility for cooking. Whatever, the mother will love to cook small things for the child, a small cooking place, everything like that, so with a very good ambience. That's what you should strive to get. I'm sure if one person starts it, others will take it up.
Thank you, Dr. Lulu. Yes, you can.
Yeah, so I know we do not want to stop this. In fact, I myself had 2-3 questions for asking, but we have been told to stop the session right here. Valedictory function is starting there in Hall A. I think I cannot thank enough Dr. Lulu ma'am, Dr. Spanna for the wonderful, sensitive conversation topic for children, and Dr. Biju, Dr. Nidhi, Dr. BG, Dr. Rajashri, Dr. Nidhi to have about Dr. Priya, please. Yeah, sorry. So wonderful session. What an exciting the last session of this wonderful academic feast it was. Let us I'll ask some questions on a personal basis only later on. So all right, I think let us close the session. Last word from the chairpersons, please.
I think that was a great session. In fact, I learned so much, and your concept, Lulu Matthew, Dr. Lulu, is wonderful for an end of life room. So, and for the people who spoke on sexuality and intimacy, it is something I also have always found very difficult to talk about and to approach patients with such issues. And I really learned how we can go about it. So thank you so much for your sessions. Wonderful.
Thanks to everyone. Thanks.
Thank you. 3 cheers for this last session.
Thank you.
Thanks, everyone.
So we log out and then go.